Asthma exacerbations are acute episodes of worsening asthma symptoms such as shortness of breath, tightening of the chest, cough, and wheezing, and it decreases the expiratory airflow. Even asthma patients with the best control at home are still at risk for exacerbation, so it's good to instruct your patient on good monitoring for exacerbations and a plan during an exacerbation at home, and for the healthcare provider to have an action plan in the healthcare setting as well to monitor exacerbations. Home management for the patient for exacerbation should incorporate 4 components of care, which include the assessment and monitoring, the patient education, environmental control and medications. It should also include a developed written asthma action plan. We need to instruct the patients how to recognize early symptoms, early signs, how to measure their peak expiratory flow, and they need to know the value that indicates a worsening asthma. They need to know how to adjust the medications to increase the short-acting inhaler if they should need it in an emergency situation, and remove or withdraw from environmental factors that are contributing to the exacerbation. They should also be instructed on how to monitor response to the meds and to seek medical care if there is serious deterioration or lack of response to treatment. Management in the urgent or emergency care setting will include assessing severity and treatment to relieve the hypoxemia and airflow obstruction and reduce the airway inflammation. The treatment strategies will include assessing initial severity by function measures for ages 5 and over, and symptom and functional assessment. We're going to give them supplemental oxygen, repetitive or continuous short-acting broncho or beta agonist. We're going to give them oral systemic corticosteroids. We're going to monitor their response with serial assessment of lung function measures, pulse ox, and symptoms, and consider an adjunctive treatment like magnesium sulfate or Heliox in severe exacerbations unresponsive to the initial treatment. And we're going to discharge them with medication and patient education. I'm going to give them instructions on how to take their medications, describe what each medication is, and we're going to set them up with a referral for follow-up care and a discharge plan, along with reviewing the inhaler techniques so that they are well educated on how to deliver their medications at home. The differential diagnostic possibilities for infants and children include the upper airway diseases of allergic rhinitis and sinusitis. Obstructions involving large airways include foreign object in the trachea or bronchus, vocal cord dysfunction, vascular rings or laryngeal webs, laryngotracheal malacia, tracheal stenosis, and bronchostenosis, enlarged lymph nodes or tumor. And obstructions involving small airways include viral bronchiolitis or obliterative bronchiolitis, cystic fibrosis, bronchopulmonary dysplasia, heart disease, and other causes. Recurrent cough not due to asthma, aspiration from swallowing mechanism dysfunction, or gastroesophageal reflux. Differential diagnostic possibilities for adults include COPD, which also includes chronic bronchitis or emphysema, congestive heart failure, pulmonary embolism, mechanical obstruction of the airways. Those would be benign and malignant tumors, pulmonary infiltration, cough secondary to drugs, and vocal cord dysfunction.